Good evening, everyone. Wanted Today I'll be talking on robotic management of Vesicoureteric reflux, the thoughts on evolution of a surgical procedure. The initial choice of topic of 20 years lessons learned from 22 decades of experience was slightly confusing, hence the change. I'm Dr. Arvind Sinha from AIMS Jodhpur. Robotic management of viewers was initially started in 2004 by Peters, and it has progressed over the last 2 decades to its current states. One of the few procedures that actually we've seen, at least I have seen from its inception to a fully established state, and uh, we want to. From during my surgical career from inception to its fully established state. So we would like to look at the lessons that we've learned in the evolution from the results, what the complication, technical modifications, and thoughts on a larger schemes of thing as far as surgical innovation evolution of a technique goes, right? If you talk about evolution of robotic management reviewer, I would try to describe it in three phases. The initial pioneering effort from 2004 to 2008, the refinement and advancement stage from 2008 to 14-15, and maturation phase of 14 to 25. So, in the initial pioneering efforts, from Peter described a uh, 2.5 centimeter length of the tunnel with a Y-shaped incision around the ureter, and he suggested a top-down suturing method. He reimplanted 22 ureter with about 8.86% success rate. The initial results were often suboptimal, variable. In 2011, Smith and Peters reported on 25 patients and with a 97% success rate with a lower analgesic requirement. However, Mohan Gundeti, in his initial 6 patients, reported a success rate of only 67% in their early cohort. In 2015, as the time progressed, 2015, the Grimsey reported VIVA resolution rate of only 72% with 10% complication rate. Same year, Sile reported a 98% VIVA resolution with only 2.7% complication rate. The maturation phase started from 2014 onwards, with wider adoption of the procedure, refinement of the technique, overcoming of the learning curve. In 2024, large European study compared laparoscopy with robotic and had 68 robotic reimplantation with 98% success rate. Systematic review also came out, which incorporated 22 studies with 1996 ureters were reimplanted with overall pooled success rate of 92% and persistent VUR of only 8.2% per ureter and with an acceptable complication rate. So variability of results were often related to case selection, surgeon's learning curve, but results also reflected the evolution of the technique, how we do the procedure over the last 2 decades, right? So let's see how the technique of robotic ureteric reimplantation has evolved over the last 2 decades. Leash Gregor was adopted for robotic ureteric reimplantation. Success rates have definitely improved. And initial attempts were initially to hug the path laid down by the open procedure very faithfully. Uh, Peters modified it slightly when he introduced the technique by doing just a Y-shaped perimeter incision around the UV junction rather than going circumferentially around the UV junction. And he created a top-down model with 2.5 centimeter length of the tunnel. Cassell, post-operative voiding dysfunction was a problem with ureteric reimplantation, and Cassell in 2008 suggested a nerve-sparing ureteric reimplant, where nerves are supposed to lie about 1.5 centimeter dorsomedial to UVJ, and he advised against extensive lateral dissection lateral and medial dissection at the level of the VUJ. In 2011, Gundeti suggested a bottom-up suturing approach where continuous suturing was done from bottom to the top. Uh, Bilateral people often recommended against bilateral surgery, and this was a no-go for extravesical ureteric reimplantation. Kasturi and Kasel in 2012, in a unique study from Philadelphia, had 150 patients with bilateral ureteric reimplantation with an operating success of nearly 100%, with no patient having voiding dysfunction. So Cassell introduced bilateral, opened the door for bilateral ureteric reimplantation by the robotic route. Hayashi in 2014 described the ureteral advancement technique where a 4-0 mattress suture at the inferior end of the detrusor tunnel was taken from the ureter also to advance the ureter the inside underneath the shelf of the bladder. This is basically what the ureteral advancement technique was all about. In 2016, Gundete et al. Studied 83 ureters and compared the results temporal over a length of time as the length of the tunnel increased, and they found that the length of tunnel of 5 centimeter was required and had the best results. And Dr. Gundeti also consolidated many of the existing technical modification into a Lua technique for robotic ureteric implanted, which was a combination of top-down and bottom-up approach. And stitches start from the bottom, and while a apical stitch holds the ureter in place. And a three-point U-stitch incorporated the ureteral advancement technique and lower Y incision, which buries the whole ureter underneath the shelf. So in 2023, a study from China actually tackled the problem of getting adequate length in younger children by suggesting that we could not limit ourselves just to the posterior wall of the bladder, but we could go on to the anterior dome of the bladder and to the anterior wall of the bladder to gain the adequate length. So these technical modifications are being adopted and they have contributed to the better outcome, right? So we've seen how the technique has evolved over the last 2 decades. So what are the lessons that we could learn from evolution of robotic ureteric reimplantation? This is one of the few procedures where we have seen the procedure progress from infancy to almost its conclusion or its finished product. It has occurred during one surgical career. I've seen it evolving during my surgical career uh, from a novelty esoteric procedure. Where we would say, I don't know how they do that, to something like that is also available an option, but the evidence is not there to fully recommend this procedure, to something which is now an established procedure where no one will doubt if you say yes, it's a definitive outcome option for treatment, and the results currently are within the margin of error. Right. Evidence for the procedure or in MIS or any surgical innovation is we've seen often heated arguments for a procedure, often ensues in conferences, and people ask routinely, where is the evidence for doing this kind of procedure? And the evidence for any new procedure we've seen with robotic reimplant is that is always backloaded. The technical modifications were mostly were available to us by about 2016. The improved results have come from 2019 and are coming to this day. So the evidence always follows the adoption of the procedure. The early adopters will adopt the procedures, the majority will accept the evidence and lead to a wider adoption. Another interesting thing about robotic ureteric reimplantation is the choice of the procedure that was actually chosen for robotic management of VUR. Ledbetter Politano and its variants were the default option for open procedure. Leash-Greger was a described procedure, but was not very commonly performed. In movie terms, you would say that Leash-Greger was an extra in a movie starred by Ledbetter, Messrs. Ledbetter and Politano. I suspect more MIS/Gregor has been done in over last 20 years than was ever done in the open era. The choice of the procedure itself often depends on the ease of that procedure being done by MIS. Purists would always be uncomfortable with deviation from the standard open technique, and I would say the existence of vesicoscopic ureteric reimplantation is a case in point. Uh, it's not just isolated incident. There are other contenders like gastroesophageal reflux in late 90s and early 2000s. Nissens and Thals used to be popular options, and I personally would always do a Thals procedure because it was always simpler as an open procedure to do a Thales procedure rather than a Nissen's procedure. And with introduction to MIS, one procedure has ascended up the totem pole, and the other has been relegated to the background, and that is part and parcel of the natural churn of the surgical progress. Um, so the choice of the procedure itself, we've seen how it is affected by the technique that we are using. How the performance of the chosen procedure also uh, uh, depends on the technique that you use. Something about the performance of the chosen procedure itself. Attempts to faithfully replicate open procedure might not work. And we've seen, as with robotic management of viewer, that it has moved from closely resembling the standard open procedure to something specifically tailored for MIS. We've seen the changes for ureteric reimplantation. And so we realize that changes are needed for laparoscopic or MIS repair, and it's unfair, and we should not expect laparoscopy to completely or faithfully replicate open procedures, right? And this change is not an isolated incident; it's everywhere. Appendicectomy in laparoscopy, we don't never bury the stump, and we ask any open uh, person who does open, and they would always bury the stump. Similarly, malrotation, where we do not never do appendicectomy. Many cases we don't do appendicectomy. Similarly, inguinal hernia, cutting of the deep ring, cutting of the sac at the deep ring was the standard part of the procedure that is no longer used for, might not be used in by many surgeons in via laparoscopy. And similarly with pyeloplasty, we would in open procedure we would attempt to excise a portion of the normal ureter before we would spatulate. We will start this spatulation. In MIS, this length has gone down, and we start spatulating very early. And similarly, in choroidal cysts, hepatoduodenostomy was never a part of open surgery anywhere. However, this is a standard part of management of choroidal cyst via robotic or laparoscopy. So this eternal struggle will always exist between purists and the innovators, and we should welcome this struggle because this struggle creates the guardrails where which prevents us from deviating very far from the established procedures. It allows surgeons to make incremental changes while preventing a completely radical change to the very nature of the procedure itself. And surgical innovation, we've realized seeing this is necessarily a messy, contentious, and often lacking in evidence. And we should eagerly await the new procedures being introduced now or evolving now, like laparoscopy management or Wilms tumor laparoscopy management or anorectal malformation, the nephron sparing surgery for Wilms tumor. Same cycle will go on. Technical modifications will come in. The procedure will be introduced. Technical modifications will come in. Uh, People will ask for evidence, and procedure will the evidence will come a few
decades, a few years later, and leading to a wider adoption. So, in conclusion, just to summarize, robotic ureteric reimplantation is the de facto go-to procedure for VUR. Results have consistently improved over the last 2 decades, and at the current moment, it's not unfair to say that it's comparable to open ureteric reimplant or laparoscopic management of VUR. And with regards to overcoming the learning curve, there is an individual learning curve, but there is a procedural learning curve that the surgical society also entails, where technical modifications and workarounds are often introduced in the procedure itself. The choice of the procedure also depends upon the approach used. What is good for open might not be good for MIS, and many good procedures might often fall to the wayside. That doesn't mean they were not successful, they were not technically good enough, but it's a natural surgical churn. The evidence-based surgery is often a misnomer. Evidence is often backloaded. It follows. So the surgical modifications generally became crystallized by 2016. The improvement in results are following from, let's say, 2019, 22 on 20 onwards. The improved results are being generated as we speak. And the struggle between purists and innovators is something which is welcome. It keeps the surgeons honest and provides acceptable guardrails for surgical innovations. You've been a very kind audience. Thank you very much.